The sun is higher today as the group gathers again in their familiar circle at the Community Wellness Center. The room feels calm, thoughtful, charged with curiosity. Today's roundtable is focused on two misunderstood and often misjudged groups of disorders: somatic symptom and related disorders and dissociative disorders. At the front, Dr. Amina Rhodes adjusts her notepad but smiles warmly at the group. She's guided many conversations about mental health, but few as layered and complex as this one. What happens when the body expresses what words cannot? When memory fragments under the weight of trauma?
Today, we're entering some deeply nuanced territory. Somatic symptom disorders often involve physical symptoms that are very real to the person, but lack a clear medical explanation. And dissociative disorders often arise from trauma, causing disruptions in memory, identity, or sense of reality. These are not attention-seeking behaviors. These are survival strategies, ways the body and brain cope when overwhelmed.
I'm Zuri. I've had stomach pain, joint aches, numbness, dizziness, you name it. Every test came back normal. I was told it was just stress, but that felt like being dismissed.
I'm Jordan. I have something called illness anxiety disorder. I constantly worry I have cancer, ALS, or some other deadly disease, even though all my scans say I'm fine.
I'm Theo. Last year, after a stressful time at work, I lost feeling in my arm for 3 days. No injury, no stroke. They called it conversion disorder.
And I'm Carmen. I have dissociative identity disorder. I've had memory gaps since childhood and sometimes feel like someone else is living inside me.
According to the DSM-5, somatic symptom and related disorders include a range of conditions in which physical symptoms cause disproportionate distress, anxiety, or disruption, even if there's no fully medical explanation. Core disorders include somatic symptom disorder, also known as SSD, illness anxiety disorder, conversion disorder, which is also called functional neurological symptom disorder, and factitious disorder, including factitious disorder imposed on another. Let's break them down. SSD is marked by one or more somatic symptoms, like pain, fatigue, or gastrointestinal distress, that are distressing or disruptive, along with excessive thoughts, feelings, or behaviors related to those symptoms. DSM-5 Criteria: one or more distressing somatic symptoms, excessive thoughts or behaviors related to health concerns like disproportionate anxiety, excessive health-related behaviors, or avoidance. Symptoms persist for 6 or more months, though the exact symptoms may vary.
That's me. I thought maybe I had an autoimmune disease or cancer. I kept pushing for tests. Even when nothing showed up, I couldn't stop worrying.
Many people with SSD feel unheard or gaslit, but research confirms their pain is real, even if the root is neurological, not physiological.
I check myself for lumps daily. I monitor my heart rate constantly. I'm convinced something's wrong even when I feel fine.
That's classic illness anxiety disorder. DSM-5 says, preoccupation with having or acquiring a serious illness. Somatic symptoms are mild or absent, high anxiety about health, excessive health-related behaviors like checking, researching, reassurance seeking, or avoidance like avoiding appointments, present for more than 6 months. This is not attention-seeking. It's rooted in catastrophic misinterpretation of bodily sensations, often reinforced by past trauma, illness exposure, or anxious temperament.
My left leg went numb and gave out while I was walking. ER scans were normal. It didn't feel psychological.
Conversion disorder involves motor or sensory symptoms that don't match known medical conditions. Common symptoms include paralysis, non-epileptic seizures, blindness or double vision, loss of coordination. According to DSM-5, at least one symptom affecting motor or sensory function. Clinical findings inconsistent with recognized conditions, not better explained by another disorder, causes significant distress or impairment. It's not faked. Individuals often have no insight that it's psychologically based.
I once knew someone who kept making her kids sick. I didn't understand what was happening at the time.
That's factitious disorder imposed on another, often called Munchausen by proxy. The DSM-5 defines two types: imposed on self, which involves falsifying symptoms or inducing illness in oneself for attention or sympathy, and imposed on another, where the same is done to someone else, often a child, and presenting them as ill. The key difference from malingering is that there's no obvious external reward, like financial gain. The motive is internal, often tied to trauma and a need for caregiving roles. The multipath model includes biological factors like a low pain threshold, abnormal brain connectivity, and hypervigilance to bodily sensations. Psychological factors such as childhood trauma, anxiety sensitivity, catastrophic thinking, and unconscious defense mechanisms. Social factors including modeling from ill family members and reinforcement from attention or care. And of course, sociocultural factors such as cultural stigmas around emotion and gender roles emphasizing passivity or sickness. Treatment begins with validating the patient, not dismissing their symptoms. Evidence-based approaches, CBT, identifying and challenging distorted health beliefs, psychoeducation, linking stress and physical symptoms, SSRI medication when comorbid anxiety or depression is present, mindfulness and interoceptive exposure, teaching body awareness without fear. Dissociative disorders involve a disruption in consciousness, memory, identity or perception. They typically follow overwhelming stress or trauma. DSM-5 categories: dissociative amnesia with or without fugue, depersonalization derealization disorder, dissociative identity disorder or DD. Characterized by the inability to recall important personal information, especially related to trauma. Subtypes: localized amnesia, can't recall events from a specific time period. Selective amnesia, can recall only parts of a traumatic event. Generalized amnesia, total memory loss of life history. Systematized amnesia, memory loss for specific categories. A rare subtype where individuals suddenly travel or assume new identities, often without awareness of their past. It usually resolves abruptly, but can be confusing or terrifying.
I sometimes feel like I'm floating outside my body, watching everything from a distance.
That's depersonalization. When the world feels unreal, that's derealization. DSM-5 requires persistent or recurrent experiences of depersonalization, derealization, or both. Reality testing remains intact. Significant distress or impairment. Unlike psychosis, people know these experiences aren't literal.
I found emails I didn't write and clothes I never bought. Then someone inside me spoke to my therapist. Her name was Lily.
DID involves two or more distinct personality states or alters each with its own patterns. Disruption in identity, memory, behavior, and perception. Gaps in recall, often for everyday events. Dissociative identity disorder, or DID, is strongly linked to severe early prolonged trauma, particularly chronic childhood abuse. Some researchers question DID's validity, citing a couple of theories. The socio-cognitive model suggests that symptoms may be influenced by media, therapy, or clinician suggestion. Additionally, iatrogenic effects imply that symptoms could be unintentionally encouraged in therapy. Yet neuroimaging shows smaller amygdala and hippocampus volume, abnormal activity in memory and emotion processing regions. Effective treatment depends on the type. Amnesia or fugue often resolves on its own. CBT and antidepressants help with related mood issues. Depersonalization, focused on grounding, reducing avoidance, managing anxiety. DID requires trauma-focused therapy with goals of building safety and trust, processing traumatic memories, promoting communication between alters, and moving toward identity integration or cooperation. Somatic and dissociative disorders ask us to listen more deeply to what the body is expressing and to what the mind is trying to survive. The pain is real, the suffering is real, and recovery is possible.
GAP3S. Let's delve into a real-world example to illustrate how these disorders are assessed and treated. Meet Emily, a 28-year-old woman who presents with chronic pain, severe fatigue, and frequent headaches. She has visited multiple specialists, undergone numerous tests, but no clear medical diagnosis has been made. GAP3S. During the initial intake, Emily shares that her symptoms began 2 years ago, coinciding with a highly stressful period at work and the sudden loss of her father. She reports feeling misunderstood and dismissed by healthcare providers, which has exacerbated her anxiety and stress. GAP3S. In the assessment phase, Emily completes a series of standardized questionnaires, including the Patient Health Questionnaire, PHQ-15, and the Somatic Symptom Scale, SSS-8. Her results indicate high levels of somatic symptoms and significant functional impairment. A detailed clinical interview reveals a pattern of health anxiety and a history of childhood trauma. GAP3S. Based on the assessment, Emily is diagnosed with somatic symptom disorder, SSD, and illness anxiety disorder. A multidisciplinary treatment plan is developed emphasizing a biopsychosocial approach. The plan includes cognitive behavioral therapy, CBT, to address maladaptive thought patterns, mindfulness-based stress reduction, MBSR, to help manage pain and anxiety, and regular follow-ups with a primary care physician to monitor her physical health. GAP3S. Emily's treatment plan also incorporates psychoeducation about her disorders, helping her understand the mind-body connection and the role of stress in exacerbating her symptoms. Over time, Emily begins to experience a reduction in symptom severity and an improvement in her quality of life. GAP3S. This case example underscores the importance of a comprehensive assessment and an individualized treatment plan in effectively managing somatic and dissociative disorders. With the right support and interventions, patients like Emily can find a path to recovery and regain control over their lives. As the group breathes together, a new clarity settles over the room. These stories, layered with misdiagnosis, trauma, and courage, now have a place, and in that space, healing begins.